Thank you, Dr. Chitra, for nice introduction and the entire ARC team for giving me this opportunity to talk on a subject which has been dear to me almost throughout my life. Why retinopathy or prematurity is becoming a big problem because this is a new disease for us. Uh, I must tell you, when I was a postgraduate, we had one para of a retrolental fibroplasia in a book, and that was it. It used to finish there. It used to be as a differential diagnosis of retinoblastoma. And now you have books, you have a society, you have so many things on this. So you can imagine why you need to know about it. And we also need to know that not only that this is going to be a big problem coming up for our country is already there. And there is also a problem that in country like India, heavier and older infants are also developing ROP, which is quite different. So what are the potential risk factors? The biggest factor is, of course, prematurity. So lower the gestation age, lower the weight, more the chances of ROP. And oxygen therapy, I think this is one of the single most in our country where unmonitored oxygen is given. And we have so many, we don't have blenders, we don't have saturation monitors. So that's why we get so much of ROP in higher birth weight babies. I have enumerated some of the factors on the other side. They are also important. What is the Indian scenario? You know, way back, this was the first thesis I had ever given in my life to one of the BGs in 91, 92, which got published in 95 as a first prospective study. You can see it was 47.27%. Even now, recently, Hungi et al., this is from the Anand Vinekar, where the incidence is almost similar. So I think problem is there. And the problem is also that we do not know which one will develop ROP among the premature children. So what we have to do, that's why it is important, and this being for postgraduate, so they have to look at it, that premature child is not born with ROP. This happens later. So screening aimed to identify that treatable stage, which is so important. And this is one disease, when the child has got a lot of problems, there's a narrow window for screening and treatment, and delay cause blindness or severe visual impairment. And there are also medical legal implications, which are probably the worst as far as ROP goes. And you can imagine the economic and the social burden of childhood blindness immense. You must understand, this is one baby or child which was born premature in a high-risk pregnancy. They have lost so many. So, and that also is blind. So you can imagine the whole thing is devastated. I think this is the time, this was the thesis with Anand Vinekar when he was with me. And this is a landmark article, which is in fact cited the most in among the ROP article from this country. Already 190 citations are there for this particular paper. Why it is important, I'm coming to that. This was his thesis, that 16% of the babies in this were above 1750 grams. So these are the babies, those who require treatment or had a severe ROP. And the 6.5% were above 2 kgs. And not only that, 23% of the babies had more than 32 weeks of period of gestation. So this helped us change the indication as far as the guidelines are concerned. Now, with great difficulty, we could get it to 2 kg birth weight, all need screening, or a 34 weeks of period of gestation. Otherwise, you can see the Western American guidelines here, 1500 grams, we would have missed so many babies. They would have gone blind. And we were not wrong. These were the guidelines in China, in Brazil, and so many other countries. And so what is important, and you must remember as a postgraduate, that the first screening has to be done before 30 days. These din Roshni ki has been given by Subhadra Jalali, and you can imagine how important it is. If it is not done before that and later, maybe it is too late. So anyone who knows indirect ophthalmoscopy and has knowledge of ROP can do very easily screening of ROP. And there are other modalities like RAT scan or a lot of wild field cameras coming in. And these are the ways of future where we're going to have screening being done. So how do you document? It's very important from PG point of view anyhow. Otherwise, you look first thing for the plus disease. Then the zone of involvement, stage and clock hours. I'll just come to that in a minute. If you see something like that, which is seen just by even naked eye, or you just focus with your 20 diopter lens, go close, you see these vessels of net, you find it is a very severe disease behind. This kind of a dilatation tortuosity seen posteriorly in 2 quadrants is a plus disease. And this is what is plus and pre-plus. If you have pre-plus, you can still call patient after 1 week, but plus disease, you need to treat them immediately. And documentation of the ROP is according to the international classification. And this is one classification which is universal. And we must know about the zones. The zone 1 is if you draw a circle twice the distance from disc to macula, and the disease in this is more severe. And the zone 2 is if you draw a circle with a nasal ora serrata, which will almost go through the almost near the equator, will be a zone 2. So most of the disease we find in zone 2, but very severe in zone 1. And if there is something in zone 3, which is a temporal crescent, it is not serious, that will usually regress of its own. Also, as far as the classification is concerned, you have avascular retina in a premature child. If there is a line which develops, it is stage 1. If this line has a volume, it is stage 2. And if it starts developing blood vessels, then it becomes a stage 3. And stage 4 is it already starts sort of detaching because that proliferation is now contracting. And if it is extrafoveal, it's stage 4A, involving the fovea is 4B. And if it goes to total retinal detachment, is stage 5. I think this is something in our country which is very often we find in outborn babies because of the unmonitored oxygen used, and 50 to 60% are aggressive posterior ROP. And this is peculiar to our country. They don't see in Western world that much. And this is something where you have a severe disease, the way I have shown here. You have dilatation, tortuosity, as well as flat vessels. Sometimes the vessels are raised and they'll go directly into retinal detachment. This is an emergency. Treat them immediately. So what are the current treatments as far as the ROP is concerned? The most important is close monitoring of oxygen saturation level, which is not happening in our country. So this is for pediatrician and neonatologist. And the peripheral retinal ablation with laser is a gold standard. We'll come to that in a minute. And vitreoretinal surgery in stage 4 and 5. Some of the emerging treatments are we are trying to target the VEGF. Here, the anti-VEGFs, again, the role has come up in a big way. Then targeting insulin-like growth factor. This is another one which is being targeted and is being used even as a marker how they develop ROP. Then dietary supplements with omega-3 polysaturated fatty acids. And the laser treatment, you see, this is after the ETDRS study that we should do laser before the threshold ROP. So even we need not know about that threshold, which was in the cryo ROP era. And what we need to know is that if you have a plus disease, you treat everything in both in zone 1 and zone 2. So that is very, very important because the indications for treatment has increased. This is after the ET ROP, and also you treat aggressive posterior ROP. And the rationale for laser treatment is that the VEGF is a stimulus for abnormal vessel, which comes from avascular retina. So ablate the avascular retina between ora and ridge to reduce VEGF. And the laser treatment is delivered with a laser indirect ophthalmoscope delivery system, and you put confluent burns, and 90% would attain a favorable outcome. That's the beauty of it. You look at this picture, how beautiful the treatment is. You do treatment, even these vessels, they become normal and everything disappears. So it's a great treatment. I think at this time, the screening and laser treatment, this was something which I learned a long time back. And this is something which can be done at this time when we are in the COVID-19. Everybody is scared. They can do it, even the screening, as well as this is way back when even still, I think Anand is with me that time in PGI. And we had shown this video all over. You just put your hands inside. You can screen through the wall. You'll not get exposed. You can treat through the wall. And that is what is required at this time. I think this idea is being taken up by anesthesiologists and others also to cover. And at this time, this is very, very handy. And we should adopt this method, which is very easily available. I think another thing which I would like to say is we are a country which is developing. We have only one laser. You can safely use just a green laser, which you have for diabetic retinopathy and other situations for retinal breaks and other, you can use also for ROP, which was almost contraindicated from the Western world earlier. So I think we have very convincingly shown, so everybody uses it, to use the same laser. We need not go for another one. We have a problem with APROP, and here the unfavorable outcome, like in our own study published in Retina, almost 71% had a favorable outcome. So we had almost close to 29% having unfavorable outcome. So that's a problem. So that's why we need probably anti-VEGF for ROP, for zone 1 and APROP, because these would be severe diseases and less responsive to laser. And sometimes the disease may progress despite your good confluent laser. And at times, vascularity is a problem when you want to do surgery. And the rescue therapy, when ophthalmologist to perform laser is not available, this is being used as an excuse by so many people just to give injection left and right, which should not be done, but is something. So this can be used as a monotherapy or combined with laser. I would say in many situations, we have to still combine it with laser. And after failed laser photocoagulation and before vitrectomy, I already mentioned, there are a lot of concerns with anti-VEGF, so we should not take it lightly like in other. Eyes treated with anti-VEGF therapy should have a frequent long-term follow-up because they have a late recurrences and we don't even know how long to follow them up. So that is the biggest problem. Child will grow up, then you find it difficult to examine such a child. Laser is a finite therapy. That's why you want to do laser wherever you can. Because once you have treated with laser, it has regressed, it will never come back. But not so with anti-VEGF. And there are concerns of a systemic adverse effects. So I'm not going into all those details. So we need to be cautious and use it only in zone 1 and APROP cases. I think lens sparing vitrectomy is a recent kind of innovation for 4A, 4B. Excellent. You can do small gauge and has very good results in these cases. Like this case here, which came from outside to us, despite laser, it progressed, and you do a lens sparing vitrectomy, even in an eye like this, and everything goes back. Stage 5 is a problem. You don't let them go there. If they go there, lensectomy, vitrectomy is required. Less than only 1/3 would reattach, and hardly very, very few, if at all, they get some vision. The visual outcome is dismal. So that's a problem. You don't want them to go to that stage 5. And there is an increasing ROP blindness in India. We have the highest preterm birth rate in the world, and increasing number of NICUs and SNCUs are government of India has opened because of the direction that we have to decrease the infant mortality, these SNCUs. And the neonatal care, I already mentioned this, and heavier, because of that, heavier babies are developing ROP, and ROP screening and treatment programs are not in place. We have to do a lot, and young people are needed. I see some of these kind of children, almost 4 to 5 every week. This is not a lens, my friend. This is a retina behind the lens. So nobody can do anything here. This child has to be blind. So we have a third epidemic of ROP because of the variable quality of neonatal care. It is even there are SNCUs being just managed not by pediatricians, by medical officers. And use of unblended and unmonitored supplement oxygen is very common. And there's lack of ROP screening program, lack of awareness, and lack of trained ophthalmologists. And in conclusion, I would like to say, identify treatable ROP with timely screening. I think that 30 days, 30 दिन रोशनी के, and if you have a child 2 kgs and below, I think must screen within a month. Manage treatable ROP promptly with laser. Use anti-VEGF in zone 1 and APROP. You may have to combine with laser. And lens sparing vitrectomy is most important early intervention of stage 4, because you don't let them to go to 5. Once they go to 5, despite lensectomy, vitrectomy, you will have a dismal visual outcome as well as anatomical outcome. So friends, I feel that a lot of you must take up and at least know what we have to do in these cases, because you can prevent a lot of childhood blindness, which is coming almost like a third epidemic in our country. Thank you very much, friends.